Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope, and I have a really interesting case for you guys. It's of a patient who suffers from chronic otitis externa. So the term otitis externa is an umbrella term given to inflammation and or infection of the external auditory meatus, also known as the ear canal. But it can also include the auricle. So the auricle, which is also known as the pinna, is the cartilage that we have either side of our head. So I always term it the satellite dish on both sides of our either side of our head. And also the outermost layer of the eardrum, the tympanic membrane. So the eardrum is 3-ply thick. The outermost layer, the superficial layer, can be regarded as part of the outer ear. The skin that forms the outer layer of the eardrum also lines the inner 2/3 of the ear canal. Then you've got the middle layer of the eardrum, which is made up of fibrous tissue, and then you've got the innermost layer, which is made up of mucosal skin cells. So mucosal skin cells are, you can compare it to the skin that lines the inside of our nasal passages or inside of our mouth. So it's more secretory. And the most common cause for chronic otitis externa is fungal infection. You may have noticed when I first went in with the iClearScope that on the right-hand side there were some hyphae, which is very, it's very common with Aspergillus, which is one strain of fungal infection. And there are also some black fungal spores posteriorly. And so when someone has a chronic fungal infection, they are very difficult to treat. This patient has been on long-term antifungal treatment, but it's something that we just have to manage. They are an elderly patient, which means their skin is naturally more drier. That's because you just don't produce the same amount of sebum, which is an oily lipid secretion which helps to moisturize the skin, and also an oily sweat that's also formed in the ear. So the skin that lines the ear canal is void of these natural moisturizers. Also, as we get older, we have less collagen in the dermis layer. And when you have less collagen, the skin becomes a bit more bumpy. And when it becomes a bit more bumpy at the surface, it's harder for dead skin to naturally migrate. So you get this shedding of skin that then collects in the ear. There was layers and layers of dead skin here. And what I'm trying to do is detach it from all the way around the periphery or around the ear canal. In retrospect, you will see in a couple of minutes, I do use the forceps and I managed to get this main plug out. And in retrospect, I probably should have used it a bit sooner. But what I was attempting is to detach it first and then use the forceps. So you can see the center of this skin plug, you've got the darker layers of skin. So the core of this plug, the skin there, the layer of skin there, was once upon a time lining the skin of the auditory meatus. Now this white layer of skin is freshly shed skin. Well, you can call it shed skin, but it's not fully shed because it's still partially attached to the ear canal. So when we refer to shed skin, we call it desquamous. So I would say this is really semi-desquamous. Although it's dead skin and it's on its way of shedding, it hasn't fully shed. And you can see the patient's dry and cracked skin on the right-hand side. That's the second bend of the ear canal. Now, I was just having a look to the last time I saw this patient, and it was only 4 months ago. So it is quite a severe build-up in that short space of time. Prior to that, I'm just having a look. It was 6 months or 7 months, sorry. Prior to that, it was 5 months. So you can see this is cycle, and we've referred the patient to the GP. They've seen the NT, and it's just a case of managing this. Now, our ears have what we call natural skin flora. So there's natural bacteria and fungi that live on the surface of the skin, and they typically aren't non-pathogenic. They don't cause any harm, and the ear canal itself doesn't really benefit from these fungi and bacteria. being in the ear, but the bacteria and fungi themselves do benefit because they've got a place of shelter, they've got food, so dead skin, sebum, the oily sweat. So wouldn't really call it a symbiotic relationship where both sides benefit. But when the conditions of the ears change, it can lead to more pathogenic bacteria colonizing the ear. And bacteria are more affected by the pH level of the ear. So the natural pH of the ear is around 5.5, maybe up to 6 even. So it's mildly acidic. And the bacteria the natural skin flora bacteria are optimal at acidic pH levels. But if the pH level of the ear increases and it becomes more neutral or alkaline, you can get more pathogenic neutrophilic bacteria, which then colonize the ear. With fungi, they're less susceptible to pH change, but more to do with humidity and moisture. Now, this patient is a hearing aid wearer. So when you wear a hearing aid, you're going to partially, at least, restrict the airflow, and that can lead to increased humidity. So I suspect that part of this patient's problem is by wearing a hearing aid. There is a ventilation hole which runs through the hearing aid itself, which does allow some air, but it's a small ventilation hole. Any larger than this patient's hearing aid will feedback, that will whistle. So it is a difficult challenge. Now, this patient, I no longer prescribe hearing aids, so the patient doesn't actually have hearing aids for myself, but I did suggest previously to see if they can increase the vent size, and I think they did, but it just led to the hearing aid whistling and the sound quality being affected. So it's a bit of a catch-22 situation. This patient is very diligent. They don't allow water in the ear. They do use acetic acid spray just to help reacidify the ear if it's slightly more neutral or even alkaline. So we want to retain that natural pH. So I used the forceps eventually, managed to remove the main bulk, and now you've just got this really thick semi-desquamous skin, so it's still partially attached to the canal, and it's a very thick blanket, very difficult to remove. So I did find this quite challenging, actually. There is going to be a bit of debris left, but you'll see at the moment you can't really visualize the eardrum. You've got all this dead skin attached to the eardrum, so once I peel it away, you're going to get a better view of the eardrum. The patient was brilliant, very still. We can see we're going very deep in the ear. I need to avoid the bone just to the right. You can see I'm like sub-millimeter with the suction tip in terms of its proximity to the canal wall. As if you make contact with that, it will be really, really uncomfortable. A bit later on in the procedure, I'm going to angle the fine end suction tip that you can see on screen, so it just helps me to gain access into that anterior recess. So our ear canal has two recesses. Normally we have an anterior recess and an inferior recess. So as the ear canal extends to the eardrum about 0.5 centimetre away, it narrows and then widens, and when it widens, in the case of the right ear, it widens to the right hand side of the ear canal towards the eardrum, so that creates a recess there, and also it widens inferiorly at the base of the ear canal, so you almost have a base and a trench there as well. And by angling the fine end, it just allows better access, particularly in the anterior recess. And it's trying to keep away the suction tip from the bony part of the ear canal. Anyone watching this on Instagram, the time limit on Instagram for videos is 15 minutes, so feel free to, if you want to watch the remainder of the video, go to my YouTube channel, just type in the Wax Whisperer or the Hair Clinic, or you can watch on Facebook. You can search for the same name, so the Wax Whisperer or the Hair Clinic. So I'm just going to the top of the ear canal. I'm trying to peel this down. It's a bit more crusty here. So we can partially see the eardrum around 10 o'clock. So this patient initially felt that there was a fault with the hearing aid, and they had an appointment booked with their prescribing audiologist the following day, but prior to attending, they just wanted to get their ears checked just in case. And once we cleared this, they reinserted the hearing aid, and they could hear significantly better. So I've got a feeling they probably cancelled their appointment. They no longer needed it. So I'm just trying to peel this down. So I wouldn't do this with a normal size suction tip. So the normal size suction tip, it's a 14 gauge or gauge. I have different people telling me differently how you pronounce it. In terms of that's based on the Birmingham gauge system. There's also a French gauge system. So typically, if you use the French gauge system, it's a 6 French gauge. And to work out the outer diameter of a French gauge, you just divide the number by 3. So if it's a 6 French gauge or gauge, it's got an outer diameter of 2 millimeters. Now, with the French gauge system, they don't always provide you with the internal diameter, which is probably for me just as important as the outer diameter. With the Birmingham gauge system, you do typically have the outer and inner diameter of the suction tube. So normally it's about 2.1 millimeter outer diameter, and internal diameter it's 1.6 or 1.7. So the thickness of the wall thickness of the suction tip is very, very thin. So with a 14 gauge suction tip, it's just a bit too big, not as delicate with a fine end. Now with the fine end, I've changed myself the size that I use, and so many of you know Connor Boland of Durham Hearing Specialist. He visited the clinic, I think it was last week or the week before, and I've got him trained up on the wax scope, and spoke to him yesterday actually, and he said he's got a great video to upload shortly, so I'm eagerly anticipating that. He really took to the wax scope because Connor, he's got a really good knowledge of photography. He was telling me how he gets his videos so sharp and clear, and it was really interesting to learn. Now, I'm not going to replicate that. That's something that I want to leave that with Connor. I don't want to step on his toes there, but he's very knowledgeable, generally about everything, but particularly about photography. And he really enjoyed the wax scope because of the soft focus. So when you look with a microscope or the wax scope, you see the object of interest in focus, but everything else is slightly out of focus. And that's how you get depth perception. He was really taken away by that. So it'd be interesting to see what he does with his video upload in terms of the way he edits it. Why did I mention Connor? Cool, we'll come back to me now. So whilst Connor was here, I introduced him to the suction tips that I'm now using. So in the UK, generally, we use a Zollner suction probe, and it's the metal capillary tube, if you want to call it that, and it's integrated into a handle. So it's either bonded or injection molded. So it comes as one piece. And if you then want to use a fine end, it's like an extension. You kind of push it on to the end of the Zollner. So what that does, it increases the length. And normally, I mean, you can get different sized fine ends, but the normal one is at 18 gauge, which, if memory serves me right, has got an outer diameter of about 1.28 and an internal diameter of about 0.83, something like that. But I'm now using a 17 gauge fine end, and the suction tips I use are completely different. So you have a separate handle, and it uses a lure lock mechanism. So the suction handle itself has a male connector, and the suction tip has a female connector, and you kind of push it on. So if I want to use the standard Zollner size suction tip, I attach a 14 gauge suction tip onto the handle, and then if I want to use a fine end, I remove that, and then I attach the 17 gauge suction tip. And the benefits of that is that first of all, this lure lock mechanism is that it doesn't extend the length of the fine end when you're using it, so it's the same length as the normal suction probe. Also, it's much easier to attach. Attaching a fine end to the end of a Zollner, it can be a bit fiddly. Sometimes you can get some fine ends that are loose, sometimes they're too tight. So this overcomes that issue, but also with the lure lock suction tips that I use, you can rotate them. Now, I'm fully aware in other parts of the world, so I've been speaking to ENT colleagues in America recently, and an audiology and nurse colleague in Australia, and also in South Africa, actually. I had a Zoom chat this last week, with the distributor there. And they all use what I'm now using in the UK, so it was interesting to learn that. So you can also rotate it, so you can hold the handle in different ways. You can have a thumb grip, pen grip, with the integrated handles and suction tips. You normally are only able to hold it in a certain way, but with this you've got the full flexibility, and price-wise they're not that much more expensive. So Connor's really taken to them. He really prefers them to the normal ones when I spoke to him yesterday. So I think we've both learnt quite a few things, actually. I've learnt a bit more about photography from him, and he's learnt about, obviously, the wax scope and these new suction tips that I'm using. And the 17 gauge compared to the 18 gauge, it's still very narrow, it's very thin, but they're less likely to get blocked, and just have a bit more suction power, so I really do prefer that. So you can see the majority of the eardrum, but you've got this very thick layer of skin here, and I just want to peel away as much as I can. If I can give this patient an extra month, not having to come back, because it is chronic for them, I'll try and do that, but it is very difficult to peel all this away, because we're literally just hovering over the bone. And it's not even hovering. Sometimes when you hover, the skin comes away and you can peel it, but here I'm having to peel it. So I'm having to go so close to the surface of the bone. As you can see under this, you've got another layer. I'll probably leave that under layer, actually, because it'd be too delicate procedure, and it would become a bit uncomfortable for the patient. But we shall see. So this skin here, this white layer of dead skin, if this is in my ear, it would naturally move sideways fully out of the ear, and the individual skin cells that are forming this sheet, this blanket, would separate. But here, it's not really migrating, it's not come fully away off the canal wall, and the individual skin cells are still interlinked. So I must admit, when the skin does come away like this, there's something quite satisfying about it. And I know a lot of viewers feel the same when you see skin being peeled. So you can see this section of the ear canal is probably a bit wider than the rest. So now it could be just years of this chronic otitis externa, and it's not eroding the canal wall. So there's no ulceration, that the epithelial skin is still intact underneath this dead skin. So it's not a canal cholesteatoma, but there is some sort of a widening. So it could be because this patient has chronic skin plugs. I wouldn't really classify as keratosis obtrans either, because there's no pain, and that's one of the hallmarks of keratosis obtrans. Patients experience otalgia, earache, but nonetheless that skin plug can compress against the side of the ear canal and initiate a process called Bony remodeling by Bony resorption. So sitting on the surface of the bone, all across the body really, are specialized cells called osteoclasts, and when you initiate those, they break down the bone into its core minerals and tissues, and then redistribute those minerals and tissue via the bloodstream to other parts of the body, where another type of cell called osteoblasts form new bone. So there could be some bony remodeling occurring on the posterior canal wall, just there where we're examining. Or maybe in the past this patient did suffer from keratosis obtrans, and it's a remnant of that. But with keratosis obtrans, you typically get more global widening, so it's not localized normally. I mean, there's always going to be individual differences, but it's not just at the back part of the ear canal, it's the whole perimeter. This is the section I was really concerned by, because I just don't know how thick this skin is, and I dread poking into the floor of the ear canal and the bony part with the fine end, so I'm playing it quite cautious here. So already the patient can hear significantly better. Here I just wanted to make sure there's no canal cholesteatoma. It's kind of a good spot for canal cholesteatoma, that is. And as I'm peeling this, I'm just hoping all of it will peel, but as you can see, it's not. It's separating in little pieces. So I think in a moment you're going to see me bend, angle, curl the fine end, wherever you wish to coin it. So with the wax scope or microscope, it's very, very difficult to visualize this, let alone gain access to it. So this is where the advantage of an endoscope is, the field of view. You can see I'm very, very close to that. I'm probably just touching the surface of that bone on the right hand side. So I think, let's see, I'm going to angle it now. I've also re-angled the endoscope. I just want to really get into that corner. Yeah, I can see the angle on the fine end. It'll become more prominent in a minute. Again, I just want to make sure there's no underlying canal cholesteatoma. Now, I think this is the early stages, very, very early stages of medial canal fibrosis. That, what I just removed, felt more fibrous. So there's a condition called false fundus or medial canal fibrosis, where you get this buildup of fibrous tissue and eventually it can form a second eardrum. And that certainly felt more fibrous tissue there. Oops, I forgot to edit this bit out. And you can get medial canal fibrosis secondary to chronic otitis externa, so during the healing process. You get granulation tissue, which then forms into fibrous tissue, and then it almost forms a second eardrum. So I was hoping to go to the top. I thought if I can peel this away, it may also then peel downwards to the top right of the eardrum. You can see there's a bit of skin there still left in we call that the anterior superior quadrant of the eardrum, just to the right of the hammer bone, the malleus. It's very difficult to gain access in there, but I think I managed to get a little bit out. We shall have a look. And by angling the fine end, I'm just creating more space. And I think I left it, and the patients found it slightly uncomfortable. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.